the nose is constructed so that there are some delicate wall that keeps the nose walls from collapsing when we breathe in. If we did not have those cartilages in our nasal walls here, this is what would happen when you breathe in. They would collapse like that. So these little cartilages here keep your nasal airways open. There's a pair low down called the alar or lower lateral cartilages, and a pair called upper lateral. Now you know that dividing the two nasal passages, there's a wall, a little septum there, that's mainly formed from a single cartilage. The quadrilateral cartilage is four sides, that's joined to the perpendicular plate of the ethmoid, that thin little piece of the ethmoid bone that sticks down. So you're normally dividing the two nasal air passages. Sometimes that septum gets deformed, like from an accident, and will heal in a crooked fashion instead of back straight. And the crookedness sometimes will obstruct one or both airways, requiring surgical correction. So you can correct that deviation of the septum surgically by elevating the mucous membrane off of it, removing the crooked part, while just leaving enough of a support here and here to keep the nose from collapsing. And then when you're done, the two little mucous membranes come back and kiss each other and heal, and you've reestablished a good airway on both sides. Now, this is a sagittal view through the nasal cavity, and showing you that it's continuous with the pharynx. So air is coming in this way. It's wafting through the nasal cavity this way. When you breathe, air doesn't go straight back like through two gun barrels. It sort of wafts up. And these little ridges right here, you might remember, are called conchae, inferior, middle, and superior. And they're little bony projections off the lateral nasal wall. They're covered with mucous membrane. So the fact that the inside on the side is like this instead of straight gives you more mucous membrane surface for that air to be exposed to that you breathe through your nose. So when you breathe through your nose, the air is being warmed, moistened, and filtered as it goes on down. Chronic mouth breathers, what happens when you breathe a lot through your mouth?
Throat gets dry.
It gets dry, doesn't it? You've probably experienced that if you've had a cold or some allergic congestion of your nose. Breathing through your mouth a lot creates a dryness of the mucous membranes, because we're not really built to breathe normally through our mouths, but of course we often do when we are working hard or exercising a lot. We'll be breathing through our mouth and our nose. All right, so this is the nasal cavity, and this is the pharynx right here. This is the pharynx. Now it's subdivided into the nasopharynx, which is the part above the soft palate. It's continuous with this part that's directly behind the mouth. This is the oropharynx. And from this point down to where the esophagus and the trachea diverge is the laryngopharynx. It's all part of the same place. But you'll notice here that this part of the pharynx is a common passageway for air and food and drink, isn't it? So what you take in here goes this way. The air you breathe goes this way.
No wonder I'm always choking.
So this is the whole picture right here. This is where we were. This is the pharynx. The pharynx is going, on the airway side, is going to be continuous with the larynx, which is this part here. This is the larynx right here, the voice box. And the larynx is continuous with the trachea, or windpipe, which divides into the major bronchi going to each lung, like this. Here are the lungs down here, contained within their pleural cavities. Notice that the right lung has 3 lobes, superior, middle, and inferior. Now, the inferior is actually bigger than that, because if you look at a lateral view, this inferior goes up like that in the back. The left side has just 2 lobes. So, right lung, 3 lobes, left lung, 2 lobes. All right, let's go down now. We come from here into here. Here is the larynx, right in here. So let's take a look at that. So here is a front view of the larynx. Now the larynx has a number of cartilages in its structure. There are 3 single cartilages in there and 3 paired cartilages. The ones we want you to know are the single cartilages. So this big one in front here is the thyroid cartilage. You can feel that with your fingers right here. It's got a little notch at the top. That's the thyroid cartilage. If you come off of that, going down, the first one you feel right here is the cricoid cartilage. So this is a single cartilage, this is a single cartilage. Now if we look at a sagittal view here, we see this other single cartilage right in the front right here. This is the epiglottis. And it's labeled right here. This is epiglottis. Here is the cartilage of epiglottis. Here is its mucous membrane covering right there. Now, the glottis, the epiglottis, is the door that opens into the larynx, the voice box, right here. The vocal cords are right here. So, when we swallow food or beverage, that bolus of food or that beverage is coming this way, like this. Now we want it to go here and not here. So as that bolus starts down, the epiglottis folds down over the opening to the larynx like that. In the swallowing process, you might have noticed when you start to swallow, your larynx moves up. The muscles that attach the larynx to the hyoid contract, and the larynx moves up. The epiglottis folds down, and your vocal cords close together like that, and you momentarily stop breathing until that bolus of food passes past here, down here, at which time the larynx comes back down, epiglottis goes up, vocal cords separate, then you breathe. That's what happens when you swallow.
Mm-hmm.
Now, sometimes we know that when we swallow, a little bit of food or beverage will get down into here and will touch around the vocal cords, or sometimes get even down here. What happens then?
Start choking
We get
and
this
coughing.
violent coughing, don't we? Because this epithelium in here is highly sensitive to foreign bodies. And so body tries to get rid of them by violently popping them out.
Right here. What I call it because you can't call it.
So again, the cartilages we want to know, to remember, there are some paired cartilages on the back here. These are the paired ones. We're not asking you to know those. Thyroid cartilage, cricoid cartilage, epiglottis. Now, as we come out of the larynx or the voice box, we're down in the trachea. So you see the upper part of the trachea here. The upper part of the trachea is in the neck. In fact, you can feel some of the tracheal rings in your neck right here. The rest of the trachea is down here in the upper mediastinum, and then it divides like that, going to the lungs. So in all, there are about 15 to 20 of these tracheal rings. Now these tracheal rings are not O-shaped. In other words, they're not closed all the way around. They're actually open in the back. So they're C-shaped. This is anterior, this is posterior. So here's tracheal cartilage, right here. Here's the lumen. The esophagus is directly posterior to the trachea. So actually, when you swallow a big bolus of food, if it needs a little more room, it can actually bulge into here just a little bit to let that bolus go down. This little muscle back here that spans the gap is called the trachealis muscle. Now, in order to do a tracheostomy, a tracheotomy, that's a temporary opening into the trachea. You normally will go in here or here, about the second or third, between the second or third tracheal rings. So you make an incision in the neck, spread the strat muscles, the sec down, you're looking at it. You make a little incision there, and you put your tube in there and secure it. This gives you a stable airway if you're going to need a long-term airway for whatever reason. Now, let's go back to this because I want to show you this right here. This is a photomicrograph of a section of trachea right here. Took a little section out here. This is what you'll see under the microscope, which one of our scopes is going to show you. One of our scopes is going to show you a segment of trachea. It's going to look very much like this. So here's the lumen up here. This is air. This is the epithelium right here. The typical epithelium of the trachea and the major bronchi is ciliated, pseudostratified, columnar epithelium. Or do you know what cilia are?
Mm-hmm.
They're little projections on the cells that have a little whip-like action that move things along. In this case, the cilia on our bronchi are moving mucus outward. Mucus that traps foreign stuff is being whipped out. We don't want those foreign particles down in our delicate air sacs. All right, now, as far as the type of epithelium is concerned, you know that columnar epithelium, simple columnar, is cells standing in parallel rows on a basement membrane down here, right?
Mm-hmm.
That's simple columnar epithelium. But that's not what this is. This is called pseudostratified columnar epithelium because it looks as if some of these cells don't touch the basement membrane. So it looks like they're layers, they're stratified. But they're not really. Every columnar cell here does actually touch the basement membrane, although you can't tell it in a two-dimensional slide. That's why it's called pseudo-stratified. Pseudo means false, doesn't it? So it's really, it looks stratified, but it's not. That's why it's called pseudo-stratified. All right, then you'll see a few mucus glands in the submucosa down here. And below that, you're down to cartilage now. So this is cartilage. It happens to be hyaline cartilage, which is the most common cartilage type in the body. There are three cartilage types, remember: hyaline, elastic, and fibrocartilage. So most of the cartilage in the body is the hyaline type. In the respiratory tract, it's all hyaline. It's the same kind of cartilage we have in our joints. It's the same kind of cartilage we have in our ribs. It's hyaline cartilage. Of course, you know, hyaline cartilage comes in different thicknesses. So, for example, this cartilage in the nose is hyaline cartilage, but it's very, very thin. Okay? The cartilage in our ribs is thick, isn't it? But it's the type. So you see these little lacunae here that contain the chondrocytes, and this is the matrix. So one of our scopes here shows you a slide that looks a lot like this. The colors of the stain are different, but it looks like that. Before we leave the larynx, let me show you this right here. This view is one in which we are looking down through the mouth into the mouth. It's as if a person were lying on a stretcher here. And we have the mouth open, and we have some way to look down in there at the larynx and the vocal cords. We're looking from above down. So this would be anterior and this would be posterior. Here's the base of the tongue right here. Here's the epiglottis. Here are the vocal cords right here. This is what you would see, or this, if you were putting a tube into somebody's trachea. You're in a situation where you had to have an airway, a stable airway, in a temporary fashion. Say they come in the emergency room in respiratory distress. They're not exchanging air. They may have facial fractures, a mouthful of broken teeth and bones and blood and everything else, and you know they're going to need to have their bones repaired and maybe their jaw wired, teeth together like this, so they're going to need an open airway, so you would do a tracheotomy in that case, but not in the emergency room. You never, ever, there's no good reason to try to do a tracheotomy in a stressful emergency situation where you got all kind of stuff going on, you don't have enough help, patient's struggling, so you just want to establish an airway. You can do that with a tube put into the mouth. Then you can leave that tube in for up to 48 hours or so. Oftentimes you're able to remove it. If you're going to need more of a stable airway after that, then you do the tracheotomy under controlled conditions in the operating room with sterile conditions and plenty of help. And as you get ready to put the tracheotomy tube in, anesthesia pulls the endotracheal tube out, you slip your tracheotomy tube in, you're done. But anyway, you've got the person lying on a stretcher here. And you've got an instrument called a laryngoscope. It's a handle with batteries in it and a little tongue-like thing that, when you flip it down, turns on a light that shines off the end of that blade. And you take a gloved thumb or a tongue blade, put it in the mouth, and raise the tongue and the jaw, and you slide this in under the tongue like this and push it down, looking, and you lift up on it. you lift the base of the tongue up, and you either get under the epiglottis or in front of it, and as you pull it up, the epiglottis will come up like this, and this is what you'll see. So you take, with your other hand, you take your endotracheal tube and slip it right down in there and secure it with tape up here. So, all of that to show you this. These are the vocal cords right here. You can see that they're close, touching each other right here. Over here, they're separated. You can see the trachea below. So, this word right here, glottis, refers to a passageway. So, the passageway is either open or closed. Here the glottis is closed. Here the glottis is open. Got it? The glottis is just a passageway. It's not a physical structure per se. I mean, if you want to put a physical structure on it, it has to do with the vocal cords, whether they're open or closed. That's what the glottis is. All right. Now, this is interesting. Let's talk about this. Give you a little quiz here. Now, to orient you, this is a look at the laryngeal area from behind. It's in a cadaver. So we're looking from behind forward. So this is the larynx proper right here, covered up with some muscle overlying these cartilages and so forth. And here's the epiglottis. Remember, epiglottis is in front like this. The epiglottis is here, and when you swallow it, folds down backwards like this. You with me? All right, so we're looking from behind at the laryngeal area. But I'm interested in what's over here.
Veins and arteries.
What is this right here?
The internal jugular vein. Wrong. Right. Well, that's an artery.
I'm right here in the neck. See?
Left
I'm
common
looking
carotid.
from behind, and I'm right here.
Common carotid artery.
Who said
Left
that?
common carotid artery.
Common carotid.
Or she's.
You're pointing fingers. Who said common carotid?
We did.
You're right. Now, which side is it?
Left.
Left. All right. Very good. So, if this is common carotid, what's this and this?
What's what and what?
Do it again. Which what?
What's this one right here?
That would be internal.
External carotid.
No, external.
Artery. You say this is an artery or a vein?
Artery.
Artery. Okay. And this would then be what?
Internal.
Internal carotid artery. Exactly. All right. If that's so, if this is the common carotid artery, what is this?
The common carotid vein.
Is it a jugular vein?
It's a vein.
It's a vein. We got that part.
It is. Well, it's blue. It's a vein.
Yeah.
All right. Now, which one is it? How many jugulars do you have?
Two.
Internal and external, right?
Oh.
So is it the internal or the external jugular vein?
Internal jugular
Internal.
vein.
Because the internal runs with the common carotid artery. All right? So far, so good. Now, this is the bonus question. What is this little thing right here? It's not a blood vessel.
The trunk.
Huh? No, it's not a vessel. Not a blood or a lymphatic vessel. not a lymph node.
Not a nerve.
No,
A nerve?
it's a nerve, all right?
Pharyngeal?
You're getting close, huh?
Oh, I'm saying pharyngeal.
No, not the pharyngeal nerve. All right, I'll give you a hint. It's a cranial nerve. One of the 10 cranial nerves. Another hint. Starts with a V.
Oh, vagus nerve.
Vagus nerve.
Duh.
That's right. I'm showing you this because next week when we do fetal pig dissection, we're going to be looking for this. We're going to be finding a common carotid artery and its associated internal jugular vein, and just behind them is a teeny little wisp of tissue, like a tiny, tiny little spring in a fetal pig, the vagus nerve. Because the common carotid artery and the internal jugular vein and the vagus nerve run together in a connective tissue sheath, part of which you see right over here, called the carotid sheath. They always run together like that. So when you look from the front, usually the common carotid is more medial, the internal jugular veins a little lateral, and just behind them is the vagus nerve. Now, vagus comes from Latin. It means to wander, or wanderer. So that's where we get the term vagabond. What is a vagabond?
Wanderer.
Somebody who roams around, right? So the vagus nerve wanders, you might say, because it has many branches and it extends from the base of the brain down through the neck to many organs. It has branches to the heart, to the lungs, to the digestive tract, to the reproductive tract. It has a far, far reach. And that's this nerve here. Of course, it's bilateral. There's a right and a left. All right, so we know that the right lung has 3 lobes, superior, middle, and inferior. As I said, the inferior lobe is bigger than just this little piece showing right here because from a lateral view, it runs up the back obliquely like that. The left lung has 2 lobes. Now here comes our trachea, right here. Here it divides, and this is the right primary or main stem bronchus, and this is the left one. These primary bronchi are in the mediastinum. They do not extend into the lungs because as soon as they touch the lungs, they divide. So here is the rule. There is a primary bronchus to each lung. Each lobe of the lung has its own bronchus. Those are secondary bronchi. So a secondary bronchus goes to each lung lobe. So there would be 3 secondary bronchi on the right, 2 secondary bronchi on the left. Inside each lobe, there are compartments. The lobe is divided into subcompartments. These are called bronchopulmonary segments. In total, on the right side, there may be 8, 9, or 10 bronchopulmonary segments. On the left side, since there's less lung tissue, there are about 8 bronchopulmonary segments. Each subdivision of a lobe, each bronchopulmonary segment has its own bronchus going to it. Those are tertiary bronchi. So primary bronchus to each lung, secondary bronchus to each lobe, tertiary bronchus to each bronchopulmonary segment. But If we look at a cast of the entire bronchial tree, we see this. We see multiple branching off of those tertiary bronchi, don't we? So you'll notice that the bronchi, as we go from central to peripheral, are progressively diminishing in size. So these are the primary bronchi. Here are secondary bronchi coming off. Tertiary bronchi are going to be smaller, and then these little tiny branches leaving smaller. So the farther out we go, the smaller in diameter the bronchial passages become. Also, the farther out we go, the less and less cartilage we have in the walls of those bronchi, and the tiny bronchi, which we call bronchioles. It's sort of like the arterial system, isn't it? As you leave the heart, the blood vessels are big, and they get progressively smaller as we go farther away from the heart. So if we keep going out, through our progressively smaller and smaller bronchi, we get down to tiny bronchi called bronchioles. Notice that by this time we have practically no cartilage in the walls. This is just muscle right here. So out at the end, we're in terminal bronchioles. We're almost to the air sacs now. These terminal bronchioles branch into respiratory bronchioles, which lead to the air sacs, the alveoli. Now let me get some terminology straight for you. One tiny little air sac is an alveolus, singular. More than one, alveoli, plural. Okay? So that's the Latin singular and plural, masculine. Now, if we look at this in a microscopic view, so here we are in a terminal bronchiole. It's not labeled, but here we would be here. If we go on out, we're now in a respiratory bronchiole. So now we're at here. If we keep on going out, this bronchiole opens into an alveolar duct, opens into alveolar sacs, and the little compartments come off of that. These tiny little compartments are the alveoli. This is where respiratory gas exchange occurs, out here. Only here. It doesn't occur in here or any way back up the line. Isn't that a lot like the blood vessels? Where does exchange occur in the blood vessels? In the capillaries. Not in arteries, not in veins, in capillaries. So respiratory gas exchange occurs in the alveoli, the air sacs. We'll talk about that more later on. Now, this last scope in the row here, all the way back, shows you a picture something like this. And there's a little note attached to it. It shows you a terminal bronchiole leading into a respiratory bronchiole leading into alveoli. You need to get that concept down because it fairly often shows up on lab exams. Now let's clarify a couple of things here. Here is a medial view of the lung. This little area that I'm circumscribing right here is called the hilus or hilum of the lung. A hilus or hilum is sort of a generic term. we saw that lymph nodes have a hilus or hilum, didn't we? We're going to find that the kidney has a hilus or a hilum. So it's not unique to the lung. But a hilum or hilus means simply this. It is an area of an organ where things are entering or leaving the organ. Blood vessels, nerves, lymphatics, that sort of thing. So anything that enters or leaves the lung happens in this little area right here, only here. In other words, there are no blood vessels or nerves entering the lung anywhere else on its medial surface or anywhere on its lateral peripheral surface. It's all right here. So pulmonary artery and vein in here. Primary bronchus in here. Autonomic nerves here. Lymphatic vessels here. All entering and leaving the lung in this little circumscribed area called the hilum or hilus of the lung. Now, I'm showing you this right here to show you this relationship right here. So we've taken a little rectangle out of there and we put it up here. Here's rib, here's intercostal muscle, here's lung. This is showing you the serous membrane lining of the lung cavity or the pleural cavity, and the serous membrane lining the outer surface or covering the outer surface of the lung right here. Now remember when we talked about the pericardium, we said that the heart grows into a space that's lined with serous membrane. And as it grows in, it carries some of that membrane on its outer surface. So in the heart, the inside of this membrane next to the heart is parietal pericardium, and the same membrane that's covering the heart itself is visceral pericardium or epicardium, the outermost layer of the heart wall. Well, the lung also grew into a space lined with a serous membrane. And when the lung grew in, it pushed into that space, carrying some of that serous membrane with it. So this membrane is called pleura. In the heart we call it pericardium. Down here we call it pleura. It's the same kind of membrane. It's a serous membrane. So that serous membrane, that pleura that is lining the thoracic wall, we call parietal pleura. That same membrane that's covering the outer surface of the lung we call visceral pleura. Now normally, those two surfaces are kissing each other. They're in constant contact. This diagram here shows you that there's a little gap or space between. I think they did this intentionally to show you what the pleural space or cavity is. But normally, when we breathe in, we take air into our lungs. Of course, our lungs are expanded against our thoracic wall inside. But when we breathe out, our lungs do not collapse and pull away from the inside of this wall. They remain kissing it. So as the rib cage expands, the lung goes with it. As the rib cage contracts when we breathe out, the lung goes with it. Normally, the two pleural surfaces don't separate. They're in constant contact. Now, abnormal conditions will cause those two surfaces to separate sometimes. But normally, they stay in touch, in contact with each other. All right. This just to remind us about the pulmonary circulation, pulmonary circuit. Okay. What is this right here? What's this?
The pulmonary trunk.
What's this and this?
The right and left pulmonary arteries.
Pulmonary arteries. I thought arteries were red. These
Not
are
on
blue.
the heart.
Less oxygen in the blood. Alright, so the red ones then are pulmonary veins, are they not?
Mm-hmm.
And why are they red instead of blue?
More
Because
oxygenated.
it's freshly oxygenated blood carried in those vessels. That's correct. Alright. Now, it is possible to measure the different volumes of air in the lung in different situations. We're not going to go into great detail about this, but I have to introduce something here because you need to know something about this, because one of the things we're going to do in this lab later is one of these pulmonary function tests. So let's look at this graph right here. This little part right here, this and this, represents your normal breathing pattern right now where you are at your desks. This is the air moving into your lungs. When you breathe in, this is the air moving out. In, out, in, out. This is called tidal volume. Normally it's around 500 milliliters. That's what you're doing right now. Now, if at the top of a breathing in cycle, you went ahead and you took in as much air as you possibly could, and then blew out all of that air that you possibly could out of your lungs, you would be moving this much air right here. You would be blowing out your inspiratory reserve volume, your tidal volume, and your expiratory reserve. Now, you can measure different volumes in the lungs, and there are ways to do that. But you can take those numbers of those volumes and convert them to pulmonary function tests of different kinds. This one right here, if you converted this volume to a lung function test, you would be measuring this, vital capacity. So you can see that from here to here is the same as from here to here. Right. We're going to be doing this in a little while. We're going to be doing this test here in the lab with our little instruments over there. That test is called vital capacity. It is one pulmonary function test. It gives you an indication of the health of your lungs, the functional capacity of your lungs. This is one such test, vital capacity. Now, let's go back over here. And you took in as much air as you could, and you blew out all of that air that you possibly could. You could not get another milliliter out. Have you emptied your lungs of all the air that they contain?
No.
No. You got this much left. It's called residual volume. All right? So you always have a little air left in your lungs under normal circumstances. What about drowning victims? They got air left in their lungs?
Mm-mm.
Probably not. This is one of the things that look for when pathologists are doing autopsies. All right. Now let's, for just a moment, let's talk about on the second page here. At the top, histology. Okay, over here on your slides, you've got normal lung. First of all, you got trachea over there that I showed you up here. You've got normal lung. Now, understand, get a good mental picture from your text or your lab manual of what normal lung looks like. I showed you normal lung up here when I was showing you respiratory bronchiole. Nothing else in the body looks like that. That's normal lung. So get that picture in your mind first. Study that slide. That's normal lung. Shows you the alveoli and so forth. Then you've also got 3 scopes over there that show you certain pathological conditions. So look at normal lung. Look at all that fine alveolar network in there. And then go look at the emphysema slide. You're going to see that there's a stark contrast. It hardly looks like lung because so many of those alveoli have been destroyed, and now you have big air spaces with a loss of significant areas of surface that's available for respiratory gas exchange. And you're going to see big bands of fibrous tissue in place of the delicate connective tissue of the lung. So that's the emphysema slide. Then you're going to see another slide over there that looks pretty much like normal lung. You can definitely see the alveoli and all the associated structures, but you're going to see a number of black flecks all scattered through the lung. Those are foreign bodies that have been phagocytized by macrophages and deposited in the connective tissue of the lung from foreign dust, in this case probably coal dust, black. So that's a case of black lung. Black lung. Then there's another slide over there of lung cancer. You can see the invasion of malignant cells into the architecture of the lung. So just look at normal lung first, and then look at those 3 variants and get that mental picture in your mind. All right, breath sounds. So have you listened to somebody's lungs or your own lungs?
Mm-hmm.
What do normal breath sounds sound like?
Clear.
They sound like a gentle breeze blowing, doesn't it? That's what you hear when you use a stethoscope on the chest like that. Because there's normal airflow, there's no obstruction, there's no turbulence. But now what if you got some junk in the respiratory passages? You've got mucus and junk in there. Instead of a smooth flow of air, now you've got turbulence. And you've got not that smooth in and out flow, gentle flow, but you've got some crackles and pops in there. It's like oftentimes listening to what you do when you got Rice Krispies in a bowl of milk. You get this crackling. Sometimes it has a very dry texture to it. Sometimes it's wetter, depending on how much fluid jumps in there. So when you have these sounds that interrupt the normal gentle in and out flow of air, you call those rowels. Rowels. Now, the exaggerated form of rowels, when you listen to the chest, it's not just a little crackly sound, but it's coarse, very obvious. You don't have to listen hard at all. It's an exaggerated form of this. These are called bronchi. This is when you really got a lot of junk in there, a lot of mucus, a lot of debris, a lot of inflammation going on. The person has accumulated mucus in there, other secretions are not clearing them, and so there's significant obstruction of respiratory passageways, and it creates very coarse breath sounds, bronchi. Sometimes when you listen to the lungs, you'll hear wheezes. as in asthma, somebody with an asthma attack. Asthma is caused by inflammation. Inflammation produces bronchoconstriction, inflammatory secretions and mucus in there, and the passageways close down like this, so that air has a hard time getting through, and so you'll hear this. And you can hear it in and out, breathing in and out. Those are wheezes that is caused by constriction of the airway. So air flows with great difficulty through those narrow passages. All right, so we're going to take us a little break, about 5 minutes or so, and when we come back, I'm going to show you this model right here. And we're going to do vital capacity. And I'm going to go over some of these respiratory models with you up here. So take a break, about 5 minutes or so, and we'll get started on that when you come back.